Hi, I'm Dr. Stephen Grover from McGill University. I'm here today to talk to you about the CCS new lipid guidelines that are going to be coming out in 2016. We've been doing cardiovascular risk assessment research at McGill University now for over 20 years. Most recently, we looked at how much do Canadians really know about their cardiovascular risk profiles. And to do this, we used the patient population that's followed at Shoppers Drug Mart and Pharmaprix across the country and gave them access to a cardiovascular risk profile. The results were particularly revealing. Among over 180,000 participants, only 10% knew both their blood pressure and lipid levels. Imagine as a physician if you're trying to treat your patients to manage their lifestyle, take their medication, and 90% don't even know what their blood pressure or lipid values are. Albert Schweitzer said many years ago, "Each patient carries his own doctor inside him. They come to us not knowing that truth. We are at our best when we give the doctor who resides within each patient a chance to go to work." How do we get the doctor in each patient to go to work? The challenge for most of us is a lack of interest by our patients. The solution is trying to engage them. Unfortunately, engagement is not as simple as one might think. At the end of the day, one has to somehow touch the intrinsic motivation of that individual if we're going to keep them engaged over the long term. In other words, simple rewards just won't do the trick. We somehow have to make risk factor management something of importance to that individual patient. We recommend that a cardiovascular risk assessment be completed every 3 to 5 years for men and women aged 40 to 75. A risk assessment may also be completed whenever a patient's expected risk status changes, such as they lose weight or they stop exercising. Options include using the 10-year risk based on the Framingham model or cardiovascular age based on the cardiovascular life expectancy model. These are strong recommendations with high-quality evidence supporting them. For instance, knowing one's cardiovascular age has been proven to improve lipid management at individuals at increased risk. In this study completed by our group nearly 10 years ago, a randomized clinical trial gave individuals the opportunity to see their cardiovascular age at baseline and every 3 months, regardless of whether they did or didn't start lipid therapy. As you can see from that second slide over on your right, the greater your cardiovascular age, or the greater the gap between your cardiovascular age and your real age, the more likely this approach was to improve your lipid management. In other words, individuals who had the highest cardiovascular age compared to their real age were 1.69 times more likely to get to their lipid targets than individuals who didn't know what their age gap was. Why is this important? Well, let's extrapolate from the recent results of the SPRINT study. Now, I realize this is a blood pressure study as opposed to a lipid study, but it tells us a lot because in this particular study, if we're going to extrapolate to the Canadian population, we're going to have to treat the majority of our patients with 3 or more medications for their blood pressure. And as you know, the more medications you have to use, the greater the problems with adherence are going to be. In this randomized clinical trial, over 9,000 persons with blood pressure greater than 130 millimeters systolic and an increased cardiovascular risk were randomized to either get their blood pressure down to 120 or a target of 140. And the primary composite outcome was myocardial infarction, coronary syndrome, stroke, heart failure, or death from cardiovascular causes. At 1 year, the mean blood pressure difference between the intensive care and the standard care groups was about 15 millimeters of mercury, so quite a difference. The intervention stopped after a median of 3.3 years, with fewer outcomes in the intervention group than in the standard care group, or a hazard ratio of about 0.75. Just for the moment, let's ignore the heart failure group, and the point I'm about to make is the hazard ratio of 0.81 that was observed in the intensive control versus the standard care group could have been predicted by that 15 millimeter drop in blood pressure. For instance, if we do a cardiovascular risk assessment of the individuals in those 2 arms of the study, if we take a look at the baseline risk of those individuals who entered the study, it was 29.7%. So they were at increased risk by virtue of the current Canadian guidelines, which say anybody over 20% is at high risk. The average individual was male. They were 68 years of age. They didn't smoke. They were slightly overweight. Their blood lipids were not terribly abnormal, and their blood pressure was just moderately elevated. At the end of 3.5 years of treatment, the intensive treatment group saw their risk drop to 24.4% as a result of their blood pressure lowering. Now, you could say to them their relative risk is 0.82, which is very close to what was actually observed, 0.81. Or you could say the number needed to treat to prevent a cardiovascular event was 19. But another way to look at it is tell them their age gap dropped by 1.1 years. In other words, their heart was now over 1 year younger than it was when they started as a result of high blood pressure control. If we compare that to an older risk male, someone who's 75 years of age, their relative risk was also 0.83 after 3.5 years of treatment. Their age gap dropped by just about a year as well. The take-home message for an older individual is there's still benefits of treating your blood pressure intensively, providing we take a look at what your cardiovascular age reduction is going to be and engage you to make sure that we get you adherent to those 3 medications. Even a young individual who wouldn't have been treated in the SPRINT study because their absolute risk at baseline was too low, their absolute risk at baseline was only 7%, and yet reducing their blood pressure gave them the same relative risk reduction of 0.81 with an age gap difference of 1.5 years as a result of intense blood pressure control. Notice in this particular case, the number needed to treat is 77. So people might get a little bit discouraged. But the fact of the matter is, blood pressure reduction over your remaining life expectancy, if you're only 40 years old to begin with, has huge potential benefits. Well, why should we spend extra time and effort to discuss a patient's cardiovascular risk? I think some of these studies give us the best information possible. This is a study looking at the incidence and determinants of primary non-adherence with prescribed medication in primary care. It was done by my colleagues here in Quebec. They looked at the incidence of medication non-adherence in primary care in nearly 16,000 patients in Quebec. Over 31% of the initial prescriptions were not filled by these patients. In other words, only 70% fill that first prescription. As C. Everett Koop said, the ex-Surgeon General of the United States, drugs don't work in people who don't take them. It gets even worse if you look over time. Among patients in Ontario who were prescribed their lipid medication and actually started it, at the end of 3 months, up to 30% stopped taking it. And over the course of 2 years in primary prevention, they were down to about 20-25% of individuals still on their therapy. Now remember, we've shown you that 30% of individuals don't even start that first prescription. So arguably, this curve should look like this, where at the end of 3 months, only about 50% of the patients we prescribe the drugs for are actually on them, and at the end of 2 years, we're down to about 10%. As Brian Haynes said for the World Health Organization, increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than any improvement in specific medical treatments. This is sobering. It means that no matter how good our therapies are, they're not going to work if the patients don't follow them. Let me finish off with a study that we're just in the middle of right now, looking at how can we engage the patient in the community to stay on his medication, to follow healthy lifestyle habits. This is a project funded by CIHR. It's a randomized clinical trial that we're running out of community pharmacies to see if we can use the community pharmacy as a health promotion center in the community. We've had some good press in this study, both in the Globe and Mail and on Radio-Canada. And the end result was over a 2-week period, 25,000 individuals logged onto the site and checked their cardiovascular age. You would think this is a great way to start a study, but let me show you some more sobering data. Among the individuals who did their cardiovascular age, at the end we offered them a couple of options. Would you like to leave the site? Would you like to register so you can track your progress? Or are you interested in our study, which will give you a comprehensive wellness program to help you exercise more, lose weight, stop smoking, etc.? What do you think happened? Well, 1.5% of those 25,000 visitors actually bought into the comprehensive program. Basic program, in other words, just tracking their progress, 1% were interested. 97.5% left the website and did nothing about their risk profile. And remember, we already know that 90% didn't even know their lipids or blood pressure levels. This is sobering data. It means that even when you offer Canadians the opportunity to change their risk factors, only a small percentage are actually interested enough, engaged enough to take you up on the offer, even when it's free. Nonetheless, 1.5% still translates into over 400 participants over 2 weeks. The important part about this is the digital interface. The digital platform offers an opportunity to go after huge numbers of Canadians so that even a small percentage results in a substantial number of participants in the study. Let me finish off with 2 more slides. My colleague Milan Gupta and his fellow researchers have shown that the majority of Canadian doctors are screening their patients no more than 70% of the time, and even these data are questionable. In the old days, they used to screen them for cardiovascular assessment using tables, such as these Framingham tables. More recently, you can get this information on the web in the sense of computerized programs. Today, I should also mention that they're finally going to become available in a smartphone setting. Why do I think smartphone is so important? It's not really for the health professionals. It's an opportunity to make it available to the patients, to try and engage them so that they come into their doctor's office with their results in hand, because nobody can then help them make changes as well as their doctor can. Not only do they know their cardiovascular risk, their 10-year Framingham risk, but they also get their cardiovascular age. And last but not least, I'm happy to mention that the Canadian Medical Association has supported this program both as a research study and going forward to engage Canadians to know more about their cardiovascular risk. The good news is our lipid guidelines are in sync with this. The 2016 recommendations, as I've mentioned, recommend doing a risk assessment, but most importantly, they recommend that the results should be shared with the patient to support shared decision-making and improve the likelihood that they will reach lipid targets. Thank you very much. It's been a pleasure talking to you today.